I see that the webinar is now streaming live.
Yep. And I have muted. And as soon as we get some people in, we can start our webinar. But everybody's going to be last minute this morning. I do know that the state is starting their budget build kickoff today. So it might be hard for some of them to join, but I pretty much heard from enough people to have a quorum. There's Michael. Go ahead and.
Hello.
Hi, Michael.
Hi, Michael.
Howdy.
Go ahead and make you a co-host.
Gotta increase my speaker volume.
Hi, Maya.
Hi, good morning, everyone.
So Michael, you should have screen sharing ability, right?
I do.
Okay.
I am empowered. Looks like it's a sunny Nevada day.
I have lights on today. It's kind of overcast today, so we might get a little bit of weather later here in the north. We'll see.
I have light snow right now.
Southern Nevada is very sunny right now.
Yeah, depends on where you are. In Carson City, we're kind of overcast here, so I prefer it sunny. I'm done with winter now. Hi, Kyra.
Hi, Kara.
Hello. I'm also
We
done
have
with winter.
Kyra, I heard you had a good call with the Oregonians yesterday.
Yes, it was good until I saw their org chart and then I got really defeated by how many
Yeah.
resources they have.
That's atypical. But they are blessed with lots of resources. But they're also still a good resource for you because they're very thoughtful and sophisticated. And,
Yeah.
and they are more than willing to share.
Yeah, they actually told us that they would even share some SAS code and stuff that they seemed very aware that they were well resourced and willing to help support us. So.
Mm-hmm.
Good morning, everybody. As soon as we have a quorum, we'll start.
Although, Leslie, this body doesn't technically vote, so does it need a quorum?
Yeah, the DAG still wants us to have a quorum to start, but I did get a lot of response. So we definitely, if everyone shows up that says they will, we'll have plenty.
Great.
So I'll give it another couple minutes.
Hi, this is Bill Welch. I just wanted to let you know I'm traveling, so I'm going to be on my cell phone. I will not be able to participate by Zoom, but I am on the call.
Okay, thanks for letting us know, Bill.
You bet. Thank you. I'm going to mute myself, but I'll be on the call.
Thank you. Good morning. Okay, town clerk. Okay, almost there. 1, 2, 3.
Hey, Leslie, this is Tom Clark. I just wanted to let you know that I'll be on audio only. I don't have a very good internet reception spot, so if I go video, it gets all crazy. So,
Oh, okay. Thanks for letting me know. And I just heard from Vance Farrow. He's going to be a little late. Stacy Sasso is here. Okay. John. Okay. While people are coming in, I'm going to go ahead and start the webinar. We have, let me make sure. I'm going to go ahead and start the webinar now. And good morning, Stakeholder Advisory Group to the PPC. I'm going to go ahead and call roll. So Angela Amar. See you. Carla B is excused. Chris Bossy, thought I saw you.
I'm here.
Okay, thank you. People are still signing on. Is Phil Burrell here? I don't think he's in yet. He may not make it, so see if he comes late. Tom Clark.
I'm here.
Is Jody Dominic here? Let's see her. And Sparrow, let me know he's going to be late. Joseph Greenway. I see you, Mr. Greenway. Can you say, do you have audio? You can see that he's there. Joan Hall.
Here.
Maya Holmes.
Here.
Shayla Holmes. She here yet? Not yet. Lawrence Lerner.
Here.
Ashore Lisek.
Present.
Karen Massey is excused today. Tom McCoy is excused today. Kyra Morgan.
Here.
Stacy Sasso.
Present.
Todd Sklemberg.
Present.
Jennifer Wakeham? I don't see Jennifer Wakeham yet. And Bill Welch, who is
Present.
on the phone. All right.
Present.
We have a quorum, so we can begin. The first
May I add
order.
that I'm here?
Oh, yes.
Sorry. Elizabeth
Thank you.
Bullhouse for SCIU. Thank you.
Yep, I see you. Thank you. I marked you as yes, even though you didn't say it. The first order of business will be to approve the January 28, 2022 minutes. Do I have a motion to approve?
I'll move.
Okay.
I'll
and-
second Angela Amar.
Okay, who made the first motion?
Shoralistic with Pharma.
Okay, thanks. I didn't see. And Angela Amar seconded. Does anyone not approve of the minutes? Nobody's saying anything. Okay, so I'm assuming that's approval, right? Okay, thank you.
Yes.
Aye.
Sorry, who just said that?
Bill and Tom.
Oh, okay, thank you. All right, we're going to go to public comment. Do we have anyone that wants to make a public comment? We have a couple people on the phone. But I don't have anyone raising their hands. Nobody's raising their hands. Does anybody have a public comment? Okay, then we will move on to agenda item 4. Michael Baylett is going to do a presentation on the discussion of transparency, accountability, and data use strategy.
Everyone, nice to be together with you again. Let me just pull up my presentation. Okay. So I've got lots to cover with you today. And I've got some questions for which I would like to solicit your feedback and then convey that feedback to the commission during its next meeting. The first thing I'd like to do, though, is just give you a sense of what the commission's going to be covering over the next few months and what we're going to talk about today and during an upcoming meeting. So this is a depiction of what was just talked about in February and what's roughly sketched out for the next several months. So you can see in February, the PPC talked about how to ensure accuracy and reliability of benchmark performance, something we've talked about already. And then they talked about transparency and accountability, which we will talk about today. This is all specific to the cost growth benchmark. And as a reminder, this advisory subcommittee was created specifically to advise the commission on the cost growth benchmark. In March, we're going to have a little bit of a diversion from the cost growth benchmark activity because one of the commission's other duties is to consider up to 3 bill drafts that they want to request per legislative session. And so they're going to have an initial conversation about this. This is not related to the cost growth benchmark, but to their broader charge. And so this will be a first conversation on this topic, the first of multiple conversations. We will then, and that will be the largest chunk of time during the meeting. And then we'll spend some time talking about the process for identification and prioritization of cost growth mitigation strategies in order to help achieve the benchmark, right? We had a meeting scheduled for April 5th. We're going to cancel that because we're not going to have enough to talk about regarding the benchmark to justify meeting on that day. So we're going to cancel that one, but we are going to meet on May 3rd because on April 20th, we are going to have a discussion of the data use strategy, which I'm going to introduce to you today. And the commission is going to review findings of a phase 1 Medicaid and PEB cost driver analysis. And this is specifically to begin to get some insight into what's driving healthcare spending growth in the Medicaid and commercial markets. We're focusing on PEB because the all payer claims database is not operational yet. And so we are using PEB as a proxy for the commercial market until the all payer claims database is populated and ready for operation. So we will talk about that, those cost driver analyses during our May meeting. And then the PPC in May is going to begin to talk about cost growth mitigation strategies to achieve the cost growth benchmark. And they'll also talk about their up to 3 bills again. In June, they're going to talk about the bill draft again. And they're going to have a conversation about quality benchmark work in other states and the state of quality in Nevada. We don't have a plan yet for July and August. In September, at their request, we're going to have a presentation from another cost growth benchmark state, potentially Oregon. And in October, we're going to talk about pre-filing requirements for their bills. So that's a rough sketch of what we've got planned for the next few months. Any questions about any of this or any comments? Okay.
Michael,
Yep.
This is Bill Welch. Thank you for reviewing the upcoming calendar. On April the 20th, you talked about the review of the findings of Medicaid and et cetera on what's been driving their costs. So what time period, who's pulling the report? Over what time period is the report or is the data being pulled for? And
Yes,
I
and
guess those are the two primary, and I guess those are my two questions. Who's doing the study? What time period? Oh, and then the third part of it was, will there be an opportunity for those providers who are part of the data that will be compiled from Medicaid and from PEB? Will they have a chance to review the data to see if they're in agreement with what that data is saying? Historically, we've had some challenges sometimes when a report is pulled and it's presented, then all of a sudden people start looking at it and they recognize that there might have been some errors in how the data was submitted or extracted. So those are the three questions. Who's doing the study, over what time period, and will there be a process of giving those providers an opportunity and payers an opportunity to validate that data before it's then presented as a conclusive report?
Yeah, so Bill, there's not going to be any reporting here at the payer or provider level. This is going to be looking at aggregate trends on what's driving healthcare spending growth in the state overall within the commercial using PEB as a proxy and Medicaid. But it's going to be market level measurement, not provider or payer level. That being said, it's going to be presented to the PPC for discussion. It's going to be presented for you for discussion. And I imagine it's going to be posted on the PPC website. We haven't talked about having a public, review or comment process, but that certainly is a possibility. In terms of your other questions about methodology, I want to note that the analysis is being performed separately for PEB and for Medicaid. For PEB, it's being performed by PEB's contractor. And they are doing it in the same fashion that it's being done for Medicaid so that we can have comparable data. In terms of the years that it's being done and how it's being done for Medicaid, I'm going to invite Kyra to talk about that because she and her colleagues are the responsible agents.
Yeah, so I welcome the opportunity to present to this group either offline or in the setting. So I'll lead with that. I think that as many people can review that and make it a valuable product, I welcome all that feedback. So happy to work with you offline or through this forum to do that. We're pulling data back to the beginning of 2016. So we're looking at 16, 17, 18, 19, and 20 with some heavy footnotes, understanding that 2020 has some weird utilization stuff happening because of the pandemic, obviously. And we're, as Michael said, looking at really high level information. So fee for service versus MCO, place of service, inpatient, versus pharmacy versus outpatient, kind of your core service categories, and statewide information. I think we break it down regionally and have some demographic information, but it's nothing that would lend itself to looking at payers or providers in any way.
Thanks, Kara.
Thank you. Thank you,
Yeah.
Kyra. Michael, if I could follow up with a question to Kyra.
Please.
So Kyra, thank you for that information. So we're looking at this in an aggregate from which we're trying to get a sense of what are the driving impacts for the spend in PEB and/or in Medicaid. So we're not going to be looking at individual providers. I understand that. Will we be looking at this from, we spent a lot of money in NICU, we spent a lot of money in oncology, we spent a lot of money in cardiology. I mean, how are we looking at this data? And if it's an aggregate form, I mean, we're going to see what's been spent over those years, 16 through 20. But how do we break it down to look at what drove either the increase or decrease in spend? I mean, in 2020, as we know, Kyra, spend went down in a lot of areas because of the COVID. But how are we going to differentiate what's going on between each of the years? So we're looking at it aggregate. But
Yeah,
what
Bill,
information are we looking at?
Bill, I've got about 15 slides on this topic coming up later today.
Okay, I'll stop then.
Hold on.
Sorry.
No, you don't have to apologize. You didn't know that. But I just want to let you know, I'm going to cover that.
Okay.
Okay. As Kyra said, these are going to be high level initial analyses. The intention, though, is to become, ever more nuanced and drill down until we have, and the PPC has, a really good understanding of what's driving healthcare spending and healthcare spending growth. Because you can't pursue strategies to improve affordability unless you know what's driving your spending and your spending growth. So
All right, thank you, Michael. I'll wait till the slides and then I'll have another question because I think this all lends to making sure that we are getting a good measurement of where we're at on a lot of different factors that drive healthcare costs or healthcare spend. And so I just want to get a sense of what we're going to be looking at and how that will play out.
You bet.
So thank you. I'll hold my questions for your 15 slides.
Okay. And as I'm going to talk about later on, this analytic work is a complement to the benchmark because the benchmark data are being submitted or will be submitted to DHHS at a summary level by the payers, meaning it won't allow for the type of drill down analysis that Kyra and her colleagues and that the PEB contractor are performing. So I've got a slide that depicts this later on, but these are two complementary activities, the benchmark measurement and this data use strategy.
Thank you, Michael.
Yeah, thanks for your questions. They're excellent. Okay, so for today, I'm going to talk about the cost growth benchmark and specifically transparency and accountability around it. This is a conversation that the PPC had at its last meeting. I will share with you what they had to say, and then I'm going to ask you for your reaction so that I can convey that back to the PPC. Then we're going to talk about the data use strategy, which is this cost driver analysis in some detail. I mean, as is always the case, if you've got a question or comment, just raise your hand. Feel free to interrupt me so that we can talk about whatever might be occurring to you. Okay, so I'm going to start with transparency. Transparency in other states that have cost growth benchmarks takes two different forms: public reporting and public hearing. The governor's executive order from December requires that there be an annual report to the governor's office on cost growth benchmark performance, but that's the extent of what it specifies. So we talked with the PPC at its last meeting about other potential options for transparency beyond a report to the governor. As a reminder, this is a diagram that I've shared with you before. It's what we've been referring to as the benchmark logic model. We've spent a lot of time talking about how we're going to measure performance relative to the cost growth benchmark and statistical considerations. What we were just talking about with these analyses to be presented in April is analysis of claim level data to understand cost trends and cost growth drivers, reporting of performance against the benchmark and of cost growth drivers. This is transparency. Okay, so this is where we are in our logic model. So one approach is to develop and publish reports. And I use the word reports, but in fact, the format can be quite variable. These are public facing documents or interactive tools to inform any number of audiences. They can be static or interactive. I mean, for example, in Washington, the Office of the Insurance Commissioner just put some interactive analyses online on their website that look at commercial spending growth patterns over multiple years. So, that's an interactive approach. In addition to the reports, there can be, brief 1-page or 2-page documents. There can be chart packs, which is just a series of graphs and tables. So a bunch of different forms are possible. They're likely to evolve over time in any state, both based on movement towards additional, more sophisticated analyses. And as there become special areas of focus, there might be greater depth of analysis. If this was to be pursued as a strategy, they would presumably be published on the PPC's website. So, so this is one transparency option. The second option that could be considered would be public hearings. The PPC could make recommendations on holding annual hearings, and if so, on a specific format frequency. This could be used to report out on cost growth benchmark performance, on cost driver analysis, to invite dialogue about what's driving spending growth and where might there be opportunities for action, including collaborative action. It can also be an opportunity to introduce policy recommendations for potentially slowing spending growth. Now, Massachusetts has public hearings. Oregon plans to begin them for the first time this April. In Massachusetts, they every year hold a 2-day public hearing following the release of an annual report on performance against their benchmark. They have an entity, the Health Policy Commission. I can't say it's exactly parallel to the Patient Protection Commission, but there's a rough parallel. And it hosts the hearings. It does so in collaboration with the Attorney General's office and with a state health data agency that goes by the name of the Center for Health Information and Analysis. Prior to the hearings, they request testimony from payers and providers be submitted. In addition to reporting out on the cost growth benchmark and other data analysis, they invite testimony from executive and or legislative branches of government. They have dialogue across payers, providers, and they invite public comment. And they make this a really big deal. They publicize it heavily. It's an event that does not occur without notice. Okay, this is just one example. I'm not sharing it as a recommendation, but it just takes this concept of a public hearing, makes it a little bit more concrete. So we asked the PPC, what do you think about public reporting? What do you think about public hearings? Do you have interest in either of these? And if so, how do you think they should be pursued? So the PPC agreed that there should be public reporting of performance, including at the payer level and at the provider entity level. As a reminder, we're talking about large provider entities. We're not talking about solo primary care practices. We're not talking about rural hospitals. These are large entities that have lots of patients that would be attributed to them. And they felt that annual hearings should be held if there's capacity to do so. So there was a little qualification there. They liked the idea, but they recognized that this was a big lift. So that's what they were thinking. Now I'd like to solicit what you might be thinking. You can see we've listed on this slide a few different questions. I invite you to respond to one or more of those questions or to share any other kind of feedback that you would like to have relayed to the commission.
Hey, Michael, no, go ahead, Chris.
Thanks. It just occurs to me, and it's kind of in follow-up to, I think, a comment that maybe Bill Welch made a little bit earlier. I would just want to make sure that whatever public reporting that we do that may end up in, a hearing circumstance, that there was a review opportunity for any entity that is being pulled out prior to finalizing it.
Sure.
Because, unintended consequences, I would hate to have hearings and have mismatch of information somehow.
Yep, absolutely. Thank you, Chris. Kara?
Oh, I was just going to say that we can easily facilitate posting this information through the Office of Analytics as well. So can fall in line with whatever the direction of the group is.
Mm-hmm. Chris, I'll share that in other states, at least when it comes to the benchmark reporting, before they put anything out at the payer or provider entity level, they share it with them privately in advance. And they solicit feedback. If necessary, the state meets with the entity and answers questions. If there's concerns about data validation, there's cycling around on that as well. And I would certainly recommend that be the case in Nevada.
Michael, this is Bill Wilson. I apologize. I'm on the phone, so I don't have the ability to raise my hand. So
no problem, Bill.
I have to interject. So following along with what Kyra and Chris just said, I guess in my mind, it seems to me as long as the reporting, I think there needs to be public reporting. I'm glad to hear that there will be a validation process before it's finalized, but I think that there also is value once that's done to have public hearings so that there can be a two-way conversation about what the report is saying, because each of us will look at the report and we may come out of it with our own conclusions on what it's trying to say. And so having a public forum where the report is discussed and all the various perspectives are given an opportunity to provide input in a two-way conversation, I think there would be a value and an opportunity to be able to develop strategies going forward if it was handled in that way.
Mm-hmm. Yeah. I mean, I would say probably the greatest value is to talk not just about the report, but what to do based on the findings, right? Maya.
I just wanted to ditto on sharing on the supporting of transparency of the data. I think this whole process is very important for the public as a whole, and so being as public as possible to expand on, what the governor laid out in the executive order, I think makes a lot of sense to ensure that there's annual reporting. If as Kira indicated, it's possible for the Office of Analytics to provide dashboards or other information. That would be fabulous, as much as resources would allow. And I think the idea of having a public hearing for folks to be able to engage is also important.
Thanks, Maya. Chris?
Sorry, just an additional thought came into my head. As you know, I can just picture kind of setting up an annual hearing process, and I'm wondering if there will be guidelines or something established about what kinds of things one would provide to help. And maybe these are, I scanned the other slides. I have to admit, I did not consume every single slide, but it seems to me that we would want to have kind of guidance about what kinds of spending would be things that we would perhaps encourage, as opposed to be worried that there is a net change. And, you know, I realize this process is about, you know, looking at the change in, or the growth in spending. But I think it's been said in several other settings that, you know, we need to be careful because we may actually be underspending in some really important areas, and we might be working really hard to fix those things. So how do we encourage the growth and access where it needs to be, while also being mindful about maybe growth that's not good? I'd like us to be thinking about how we differentiate the growth, and we look at bad growth and we measure it against a benchmark, but how do we identify good growth? Is there any intention that we will actually be benchmarking our spending maybe by service area to say, wow, we're way below in this area. Like we might be low in mental health, for example, because we don't have access to providers, and we win if we get more providers. So I won't belabor it, but I'm hoping that we'll get to a place where we can look at good growth and then look at growth that maybe we want to start minimizing.
Yeah, absolutely. I've participated in conversations in other states where they've said, if we go over a cost growth benchmark for primary care spending or outpatient behavioral health, that's okay. But we want to come in under the benchmark in the other areas. And of course, net come in under the benchmark. But in general, certain types of spending growth in excess of the benchmark might be a desirable public good. Yeah, thank you for that, Chris. Anybody else have thoughts on these two questions about transparency through public reporting or public hearings? No, I'll add, the formality of the public hearings can be variable. So they're quite formal in Massachusetts. I think they're going to be a little less formal in Oregon, and they're even less formal in Rhode Island, where they don't have a hearing. Actually, they just call it a public meeting. They're covering a lot of the same topic, but it's just a little less formal, and it's half a day rather than 2 days. So there are a range of options in terms of how this is technically structured and for how long. All right, I don't see any other hands or voices. So thank you for your input on this. So let's talk about accountability now. Accountability is really about what are the procedures if there's a provider entity, again, a large provider entity or a payer that does not restrain spending growth to be at or below the cost growth benchmark. There are 2 states only so far that have created accountability consequences. I want to note that governor's executive order does not direct any accountability mechanisms. Okay, so there are none. So I'm sharing with you what a couple of other states have done, but note that there's no direction that there should be any in Nevada right now. So the 2 approaches are the creation of performance improvement plans, and Massachusetts and Oregon have done this, and financial penalties, and only Oregon has done this so far. Although I think Massachusetts might be considering it this legislative session. So this is the accountability process in Massachusetts right now. It's a lengthy one. They collect data relative to their benchmark, and it's analyzed by their data agency, which is CHIA. It then sends it to their health policy commission that reviews the performance, and then they decide whether or not to require a performance improvement plan. And then they require that either a payer or a provider submit a performance improvement plan and undergo monitoring over a year and a half. If they don't do so, then they can be assessed a fine of up to $500,000. But that's only if they don't follow the performance improvement plan. Otherwise, there are no financial implications for failure to remain below the benchmark. Now, you may not all remember this, but Massachusetts was the first state to create a cost growth benchmark strategy, and they did so through 2012 legislation. They never required a performance improvement plan until this year. And that surprised a lot of people, but the primary reason is because Massachusetts, until the last 2 years, was keeping its spending growth on average at its cost growth benchmark. And so I can only speculate, but my sense is they were probably thinking, overall, we're doing okay. So the fact that we have some that are above, we're going to let go for right now. But then the whole state growth rate exceeded their benchmark. And so for the first time, they created a performance improvement plan, and it actually became a national news story. So this is the press release from the Health Policy Commission. They found that the largest health system in the state, Mass General Brigham, exceeded their cost growth benchmark, and you can see the findings here on the right. This is specific language from the Health Policy Commission in terms of their exceeding the benchmark. Now, they're noting that they exceeded between 2014 and 2019. So clearly, they took quite a while before taking action. And then this bullet on the bottom right identifies what the performance improvement plan had to include. Okay, so this is an example of a performance improvement plan. I'll note that in addition, the Health Policy Commission released a report in the fall of or late last year that also made recommendations for tightening their tools relative to their cost growth benchmark. Chris.
Just a comment. I hope that whatever process gets implemented in Nevada is this just feel. I have no idea. I know that $293 million over 5 years sounds like a big number to the public. And I realize none of us on this call put together this thing that was published somewhere. Yeah. But as a group, I would hope that we would all try to give whatever it is we're reporting context, because this could be like 1% above what the benchmark is, because you don't know how big this organization is, and we're reporting this huge number and wanting people to react. And I realize that's not, newspaper writers do that, but I would hope that our rules of engagement would be about fairly reporting the context of what we are sharing with the public and not trying to scare people.
Yeah, well, and again, the governor's executive order doesn't call for doing this. Okay, so I'm just sharing an example from another state. Okay, and not as a model, just as an example of, how one state has implemented a performance improvement plan. They also, in their September report, recommended strengthening accountability for excessive spending. And this is because they've exceeded their cost growth benchmark 2 years in a row. So they were very happy and proud about how well it was working until it stopped working. And so now they're thinking about what they need to do. You can see increasing financial penalties for above benchmark spending or non-compliance. They actually had no penalties for it before. But after having just public reporting as their accountability tool for a half dozen years, they are now proposing stronger measures. So here's information from Oregon. So Oregon's had two pieces of legislation. They already had a performance improvement plan that was sketched out in very rough terms, but they had subsequent legislation last May that gave them their agency, the Oregon Health Authority, two specific directives. One, to require a performance improvement plan with a provider or payer that exceeds their cost growth benchmark. I should note that it's for exceeding it without reasonable cause. I don't think that's the exact language, but that's the concept. And then imposing a financial penalty for exceeding the cost growth benchmark without reasonable cause in 3 out of 5 years, or for not participating in the program, meaning, you were asked to submit a performance improvement plan, you said, forget it, I'm not doing it. And so that, that reasonable cause concept, I think that was applied in Massachusetts, although they don't say that. It certainly was part of the policy development in Oregon. And so what might reasonable cause be? Well, I would expect that cost growth in 2021 is going to be pretty high on a per capita basis because spending was depressed in 2020. All right. So I think probably anyone would say it's reasonable that spending for 2021 would have exceeded a benchmark. Now, of course, Nevada didn't have a benchmark in 2021, but if there had been one, it probably would have been exceeded. Okay. And for a reasonable reason. Right. They haven't applied any of these tools yet because their benchmark just became effective 2021. So they haven't even done their first year of reporting yet.
So Michael.
Yep, good. Bill?
Sorry, Michael. So you gave an example of reasonable cause for exceeding the benchmark. So in Oregon or Massachusetts, have they actually defined in writing the parameters for what might be considered reasonable cause? Or is it just say reasonable cause and then we have the debate at each year as to whether that was reasonable or not? Or at least, or are they trying to give some guidance as to what would be reasonable cause?
Yeah, I don't think there's anything published in Massachusetts on what they consider. I mean, including this concept of reasonable cause. But in Oregon, they were transparent and they developed, they identified examples, multiple examples of conditions that represented reasonable cause, but it's not a definitive list, Bill. And I think that's in part because you can't anticipate all scenarios. I mean, none of us anticipated a pandemic. I know in Massachusetts, they had 1 year where they exceeded their benchmark, but everyone said it was okay because it was the year that Sovaldi was introduced into the market. And, hepatitis C was cured. So everybody felt okay about exceeding the benchmark that year. So we shared this information with the PPC. Again, this was just as a point of information. The executive order doesn't call for any of this. Interestingly, where their conversation went was they started talking about quality. And they said, we've got a cost benchmark. Should we have something for quality too? And so they asked that there be a future discussion during a PPC meeting about the concept of quality benchmarks. There are, in fact, 2 states that have quality benchmarks that complement their cost growth benchmark. And so we're going to talk about that in a future meeting, which you saw in the meeting plan I shared on an earlier slide. They also want to review data that profiles healthcare quality in Nevada relative to other states. So that will be a discussion topic. So let me pause now and ask if you've got any reflections on either the accountability work in Massachusetts and Oregon or on this interest among commission members in the idea of quality benchmarks. Chris?
For me, the piece here that talks about quality reporting and quality performance compared to other states might be a place that we would also look at cost compared to other states. So, you know, while we might be setting a growth benchmark, I still think it's super important that we pay attention where we can measure it. If where our overall spending is, or spending by sector, or however we can measure it and how we compare to other states, so we don't get lost, you know, lost in the forest without, you know, anyway, I get nobody wants to increase. I understand that, but I'm worried that we will end up having unintended consequences. So.
Okay, thank you. Anybody else want to share comments? Okay, so I'm going to transition now. So all this content that I've just shared with you is content that we discussed with the commission. Now I'm going to talk with you about these data analyses that we're going to have presented to the commission and then to you in May, and what's planned not just for the next few months, but over the longer term. So we're calling this right now the data use strategy. I want to distinguish it from the benchmark analysis. I talked about this earlier. So the benchmark analysis is asking the question, how much did per capita cost grow from the prior year to the year following? Okay, we're using aggregate data to do this. It's coming from the payers, Medicare, Medicaid Advantage, Medicare Advantage plans, Medicaid managed care, Medicaid fee-for-service, and then commercial payers for both insured and self-insured covered lives. Okay, it's the data will be analyzed by the Office of Analytics at DHHS. What I'm about to talk about is analyzing not aggregate data, but granular data, which is claim level data. Okay, this is a complement to the benchmark analysis because it allows much more detailed understanding of what's driving the trends that are observed in the benchmark analysis. Okay, so this in time is going to use the all payer claims database data when it's available. But until then, we're going to be using Medicaid claim data, including from the managed care plans and PEB claim data. And as I indicated earlier, Office of Analytics staff will analyze the Medicaid data, and PEB's contractor, Aon, is going to analyze the PEB data, but using the same approach that the Office of Analytics is. So why do this data use strategy? As I indicated much earlier, you can take actions to slow healthcare spending growth if you don't understand where it's occurring. And that's what we're trying to do here. Trying to get insight into where spending is growing and why, where it's variable and why. And we use the term data use strategy because the intent is to use the information to inform strategic action. And that action might be unilateral sometimes, or it might be multilateral. It's really going to depend upon what are the contributing factors. So the plan is to develop a set of standardized analyses that will be repeated every year and allow the PPC, allow this body, and allow the public to track what's going on in healthcare spending in the state and what's driving healthcare spending. Right now, Medicaid and PEB are focused on phase 1 analyses, which are some high-level standard analyses. They will be followed later in the year by the development of the phase 2 analyses. So all this analysis is trying to answer, these fundamental questions. Where is spending problematic? And when we're trying to identify where it's problematic, we're trying to look at where is it high, where is it growing, where is it variable, and where is it out of line with benchmarks? Okay, so Chris, to your part, this is benchmarking, say, with other states. After we've asked where it's problematic, we want to understand, well, why? And the initial analysis we'll look at, is it price? Is it volume or utilization? Is it intensity of services or service mix? Or is it changing population characteristics? And then finally, who's accountable? And so this means looking at the information, yes, of course, at the state level, but also looking at the market level. So is spending growing faster in one market versus another? Is it growing faster with some payers or with some providers relative to others? So these are the core questions: where, what, and who. And the analyses that follow try to answer these questions. So when we're looking at where spending is problematic, we're going to look at spending both at a point in time and as it changes over time. And that would include by service category. So I think, Bill, earlier you asked, are we going to be looking at oncology? Well, yeah, in time, we're going to look at it by service category. We're going to start with broad service categories, and we're going to get more nuanced. So we're probably going to start with broad categories like professional services, hospital inpatient, hospital outpatient, pharmacy, et cetera. But we're then going to become more nuanced in our understanding of what's happening in each of those categories. We'll also in time want to look at how spending varies across regions, payers, and providers. There's a lot of regional variation we've seen already in spending in the state, but we're probably also going to see variation in payers and providers. And then again, comparison to benchmarks, there are a bunch of available benchmarks. A couple that other states use frequently are the Healthcare Cost Institute benchmarks, and specific to hospital spending, RAND benchmarks. As I said, we're going to try to break down spending, looking at the role of price, the role of utilization or volume, the intensity of services or service mix. So for example, we want to capture changes in site of care and in treatment modality, including treatment intensity, the population of patients being served, and provider supply. So these first four categories, we can actually, it's not easy, but there are ways to disentangle them using claim data. Provider supply is really a separate issue. And frankly, in Nevada, where there are shortages of providers, it's probably less of a cost driver than in some other states. So this is an example of an analysis from the Washington Health Alliance, which is a nonprofit that has a big multi-payer claims database. And you can, this is a few years old, but you can see they broke down the contributors to spending by demographics, which they looked at age and gender, service frequency, so that's volume, treatment intensity, and price. And they did so here for a bunch of different, well, it's a combination of medical conditions and procedures. And then they disentangled what was the contribution of each of these four factors. So 65% of the change in PMPM spending was price, 18% was volume, and 9 and 8% was increased intensity and probably an aging population. Okay, so this is an example, not of something that we're replicating, but it's an example of a breakdown to better understand what's driving spending. So then the third question was who's accountable, and there are lots of ways to break down spending. So the starting construct is to do state, market, payer, and provider entity. Within the state, it's possible to do geographic breakdowns. Medicaid, for example, does north, south, and rural. That's one way to do it in the state. For market, commercial, Medicaid, and Medicare are the three primary categories I think that we're likely to look at. There are certainly subcategories within each of those. So in one state in which we work, they look separately at Medicare Advantage and traditional Medicare because there were big differences there. By payer, so this is obviously individual payer, you could do it by product, although I'm not aware of states doing that right now. And provider entity, so the benchmark is going to be looking at large provider entities that have lots of attributed lives. But for the purposes of the data use strategy, it's possible to look at smaller units of analysis. And you could look at particular medical specialties. You could look at all hospitals if you wanted to. You could look at care by site of service. So in one state, they recently looked at the interplay between urgent care centers and ED utilization. So in using this detailed claim data, it's possible to look at cost drivers, not just at the big, large, accountable provider entity level, but at subcategories as well. So before I go on, any questions on anything that I've covered so far? All right, so now I'm going to talk about the phase 1 analyses. So Bill, this is what's planned at the start, not at the finish, but at the start. We have recommended to states that they start with 11 standard analytic reports. We wrote a report that lays this out, or a brief, for the Peterson-Milbank program that they published last June. And we recommended these 11 standard reports. We recommended that there be multiple years of data, as you heard from Kyra earlier. At least for Medicaid, they're looking at 2016 to 2020, which is great, because if you see only 1 year's trend, you can really get a distorted perspective of what's going on. But if you've got 5 years, patterns become pretty clear. We've recommended that these reports be produced on both a total spend and a per capita spending basis, and that they be released at the same time as cost growth benchmark data, because it helps inform an understanding of the cost growth benchmark data. So these are the 11 reports. Chris.
Thanks. So is like service intensity, I'm curious, and it might be too detailed of a question, but I'm sitting here trying to think of what the report would look like, and are we risk adjusting? Are we, how are we identifying kind of what we're using as the benchmark or the comparison to determine the effects of population characteristics, service intensity? How are we determining what we have as high or low?
Yeah, those are great questions. So on service intensity, there's no one standard methodology for doing this. Recently, on behalf of all the Peterson-Milbank states, we've been talking with the Healthcare Costs Institute, which has developed a methodology for doing this, about potentially helping each of the states adopt that methodology. And in fact, we're doing a webinar on this in a couple of weeks for the states. So that's a possibility. It's complicated because you're looking at, for example, a substitution of a CAT scan for an X-ray, right? Because that's more intensive. Or moving from specialty drug to a generic. Well, that's a reduction in intensity. Or moving from surgery in a hospital outpatient setting to in a freestanding surgical center. So these are all examples of changes in service mix or in intensity. And so it's complicated having an algorithm that captures all of them. But it's important because if you don't capture all of them, then they all show up as changes in price when they're not necessarily changes in price. They're changes in services. So that's why we want to isolate them. In terms of population demographics, so there are three different considerations here. The simple one is age, sex. That's easy to capture. There are easy ways to adjust for it. The second area that's often of interest is capturing social risk or social determinants of health. There's a lot of interest in adjusting for that. But, and we spent a lot of time looking at this, there's not a standard acceptable way for doing it in a way that would not potentially create more harm than good. The third question is clinical risk adjustment. So patients get sicker, right? And they never get healthier, they just get sicker. So this is particularly complicated because there's now lots of evidence that shows that risk scores across the country reflecting clinical risk have been growing at rates that seem to be higher than actual changes in population health status. And that's largely because of improvements in completeness of coding of claims with patient diagnoses. So we've talked about this actually here and with the PPC because it potentially distorts analyses of spending growth because you over adjust because it appears that a population got sicker than it actually did. Right. So the trend, not just in Nevada where the PPC actually just decided or just recommended to the state that there be no risk adjustment, but in other states too, they're moving away from clinical risk adjustment and they're either doing age, sex alone for their cost growth benchmark analysis, or they're doing nothing because they can't figure out a way to adjust for the growth in coding completeness. So these are the 11 reports. And, you know, they start by looking at what's happening in spending by market. That's commercial, Medicare, Medicaid on a per capita basis and in a total spend basis. So that's 1 and 2. By geography, however defined by the state. By broad service category. So that's what I was referring to before. By health condition. And so this is often looking at people who've got chronic conditions and what spending look like for them. By demographic variables. So this can be age and sex, but it can also be race and income and other considerations. If you're going to do things like race and income and ethnicity, you're going to have to bring in data from sources other than claim sets because that's not found there. But you can impute that information from Census Bureau data. And then last is measuring whether there are unintended consequences from the cost growth benchmark. So this is what we refer to as a starter set or phase 1 analyses. Nevada initially, for its phase 1, is going to pursue the measures that you see here in boldface. All right, so most of them, but not all. For market, we're getting 2/3 of the way there. So the initial analysis is going to include Medicaid and PEB, but it won't have the full commercial market or even the full insured commercial market because the APCD is not live. And for the same reason, no Medicare. Health condition won't be done initially, hopefully in phase 2, and measurement of cost growth target unintended consequences, not right away. So, so this first set of reports will provide some understanding of what was going on before the benchmark became effective. It's only going to do so, as I told Bill, at the state and market state and market levels. That doesn't mean in the future it won't include provider and payer level, but it won't initially. So here are examples from other states of what these look like. So this is spending by market. This is an example from Rhode Island. You can see their per capita trend, commercial 3.4, Medicaid 5.8. Usually, actually, we see them flipped. Usually commercial is higher. But for their baseline or their pre-benchmark, this is what they reported. I want to note that these analyses that are going to come out of claims data are not going to align perfectly with the cost growth benchmark data. Even when the full APCD is being used, it won't be the same because the methodology is not exactly the same and the APCD won't have the commercial self-insured population. This looks at spend and trend by geography. This example is from Rhode Island. They did it by county. It's not saying county is right, but you've got 4 years of trend here by county. You can also see there's a lot of variation in spending by county. And this is just looking at inpatient spending per unit, which is, I think, per discharge. So Fairfield County, $28,000, and Windham County, $22,000. Okay, so fair amount of variation in a small state. And again, these aren't recommendations, just examples of how other states have operationalized them. And sometimes they've done them in more ways than what I'm showing. Looking at trend by service category, this is an example from Oregon. It's actually an old example. So on the left, you can see trend over time in primary care visits per 1,000 member months by payer and market. So you see the absolute level and how it's trending, and inpatient admissions and how it's trending. Okay, you can also see over here by broad service categories and by market, commercial, Medicaid, and Medicare. We've recommended starting with categories from the National Health Expenditures accounts, but each state is free to use whatever categories it wants. We only provided recommendations of so people knew where to start, but there's not necessarily one way to do this. In terms of looking at spending and trend by health condition, this is an example, again, from Connecticut. You can see they're looking at spending for trend for all members by chronic condition, for people with one or more conditions, or people with two or more conditions. So their whole population spending per member per year was $6,000, but for people with hypertension, $14,000, more than twice the all members. So you can see what impact the existence of one chronic condition, now some of these people obviously have comorbidities, has on spending. We propose use of CMS's chronic condition warehouse, but again, the state can use other approaches. That's not the only one. And then this is an analysis looking at demographics. So this does include income, and it includes a rather crude measure of race. It's the percentage of the population that's white. This looks at total spending and also ED utilization. They found a very strong statistical relationship, as you can see here, in ED utilization between race and income. Now, interestingly, a subsequent analysis repeated this, but it controlled for age, sex, and for chronic condition prevalence. And once they did that, the variation was eliminated.
Michael, there's a comment from Chris in the chat.
Slide 32, case mix adjusted. Let me look at what 32 is, Chris. So it was age gender adjusted, Chris.
Okay, it just seems kind of crazy that it wouldn't at least be case mix adjusted, because there might have been a bunch of high risk, whatever patients in one area versus another.
Well, but you wouldn't have that every single year, right? Right. I mean, that's 4 years of data.
Yeah,
But I will also say, so, Chris, the case mix problem is similar to the risk adjustment problem. Is, some of the increases in case mix are due to changes in documentation of conditions that results in patients going from one DRG to the next. And so Massachusetts did a study where they looked at changes in hospital case mix, and they looked to validate it by looking at other measures, length of stay, ICU utilization, and they could not find any supporting evidence of the growing case mix scores based on any other indicators.
yeah. I guess I'm just looking at this and I'm sitting here thinking, okay, I'll be silly for a second. Maybe Litchfield is near a ski hill and they have a lot of orthopedic cases that happen there compared to, and maybe the key is only the change year over year. And so it doesn't really matter. We're not really comparing each of these locations, because it may just be that there are sicker people in one community versus another. One's near a coal mine.
Yes.
I don't know.
Yep, for sure.
Okay.
But I would say this is another reason, though, why you want to also do multi-year analysis, and not assume from 1 year that something happened. And you can see in some of these counties, it was a little, that the patterns are not smooth. I mean, in Fairfield, it's like climbing a mountain, but it's not that way in Windham, for example. I will say that one thing that was correlated is the 3 counties with the highest spending are the 3 counties with the greatest market power concentration in their hospital industry. I can't say that's causation or not, but it's correlation. But these types of analyses, are intended to be lifted up for transparency and conversation about what does this mean, right? And let people talk about it and say, well, what should we be controlling for? And can we finally come to some agreement that we've controlled for enough things and we can make a conclusion about what's going on? But without taking this type of data and putting it public in front of groups like you and others, you can't have the conversation.
I appreciate that for sure.
Yeah, thank you, Chris. Okay, and the last recommended report is looking at unintended consequences. I want to note there is no evidence that providers restrict patients from receiving necessary services because there's a cost growth benchmark. There's none, but in some states, not in all, there have been consumers who voiced concern that that could happen. And certainly, theoretically, it could happen. So we've suggested that states implement some measurement to at least monitor for potential unintended adverse consequences. Now, of course, lots of other things motivate behavior of clinicians and provider organizations, and the cost growth benchmark may not be the strongest one, but nonetheless, having some set of measures for tracking impact is probably a wise thing to do. And we've given examples of the types of analyses that could be performed here. And in fact, there are 2 states that have developed analytic plans for this in response to the development of their cost growth benchmark. All right, so these are the 11. We've also recommended a set of phase 2 analyses. So in phase 2, we recommend going down to looking at provider and payer level analysis, looking at variation across payers and providers, considering whether supply is a cost driver. As I said earlier, I'm not sure if that would be something I would prioritize as highly in Nevada as I might in another state. looking at market consolidation as a cost driver. There's so much literature on market consolidation driving costs that I think that's necessary. Special focus on pharmacy is warranted because in all of the states in which we're working, pharmacy is one of the two most significant cost drivers for multiple reasons, not just the new infusion drugs, but it's got the highest trend over multiple years. Not every year, but if you do a 5-year assessment, it's growing faster there than almost any place else. Out-of-pocket spending gives some insight into what's going on with consumers and how much is spending growing for consumers, because Massachusetts found that they slowed their rate of growth in overall spending, but the consumer spending growth grew much faster than overall spending. And that's because of the increased use of high deductibles and coinsurance. So the spending growth rate was coming down, but consumers were not benefiting from it. Benchmarking I talked about before. Special analysis of site of care is an opportunity to highlight opportunities for savings. And finally, looking at specific physician specialties. So these are all sort of a next wave. I think that that probably 1, 2, 5, and 7 are the ones I might start with next. So there are lots of other areas for potential inquiry, and all of you and the PPC and other stakeholders might identify them and say, hey, I think we should focus over here. What's important, though, is that there be a set of standardized analyses that get run every year and that serve as an ongoing monitoring system. And then the ad hoc analyses that drill down can follow from there. But first, you need something of a dashboard with standard measures that get looked at every year. And that's what we're talking about with most of these phase 1 and phase 2 analyses. And then it gets shared in ways that people can understand. And as we've talked about, we have a basis then for conversation. So anybody else have any comments? I've heard from Chris, but I haven't heard from anybody else for quite some time. Yes, Lawrence?
Yeah, in my field of nephrology, I think there's 2 new drugs that impact 2 of the areas you've talked about. Kind of like the hepatitis C, there was a huge initial spend to treat those patients, but we hope long-term that it actually prevents costs. There are 2 new drugs that help slow the progression of chronic kidney disease. And you talked about the incentives for underutilizing care. The insurance companies have already made a decision in many cases that they won't cover these drugs, at least this current plan year. But we feel in nephrology that if these 2 drugs are used, they will save money in the long run by preventing a lot of patients going on dialysis, which we all know is hugely expensive.
Right.
And these 2 drugs both cost about $600 per month without insurance.
Got it. Yeah. So, this is a good case example. Let's say that the phase 2 reports tracked spending by physician specialty, and somebody said, what the heck's going on with nephrology? Spending's growing 30% a year there. So then there would be a conversation where someone like you might say, well, why don't you take a look at the pharmacy that you are including under nephrology? I'll note that, frankly, it might not, Lawrence, actually even show up under nephrology. It might show up under pharmacy, but let's say that it's included with nephrology. So then there's a conversation. People say, they might say a couple things. One is they might say, this is good spending, and even though it's high, we're all right with it. They might also say, well, the drug is good, but the $600 a month isn't so good, and we have a price problem there, and we should do something about that. All right, those are a couple of possible responses. I'm just conjecturing. But again, you can't have the conversation until you're measuring and you see that there's very high growth in a certain area. That then allows you to have a conversation about, is that acceptable spending that we think is a public good and a patient good or not? All right, so the plan is in April, there's going to be a first report looking at Medicaid and PEB spending, covering those phase 1 reports that were in bold font a few slides earlier. And then over the summer, we're hoping for a phase 2 that will include some more complex analyses. Maybe, if not then maybe later in the year, some ad hoc drill down analyses, because maybe when we share with you the phase 1 analyses, you're going to ask some questions and the PPC is going to ask some questions and say, could you look at this further? Help us understand what's going on in hospital outpatient spending and why it's growing so much. So then there might be subsequent analysis. I'm just an example. I have no idea what hospital outpatient spending growth was, but that's just an example. So lots coming out over the coming months. And then in 2023, we're going to have our baseline cost growth benchmark report. So we're going to look at what was spending in the state for 2018, 2019 using aggregate data. This is a little bit of a dry run. We'll have public reporting by market and at the state level. There won't, for this baseline report, be publicly reported performance by payer or by large provider entity. Okay, that will come the subsequent year. But this will be our first time measuring benchmark performance, but for a year prior to the benchmark and for a year prior to COVID. All right, any comments or questions on this data use strategy? I just covered a lot of slides with you. It's a little weedy, but this is really critical, because after you set a benchmark, you can't just, say, all right, we're all done, let's all go home. In many ways, that's when the work starts. And these analyses are about understanding what's happening underneath the benchmark so that there can be discussion and then action to have healthcare spending grow at an affordable pace.
Michael, this is Bill Welch. Thank you for the presentation. And he did answer a lot of my questions in these additional slides. Just a general observation, if I might. As you pointed out, and as comments have been made today, we don't know what we don't know, so there's going to be factors that come up that we just don't anticipate today. So to your point, I hope that as we deal, and you gave a couple of examples of what might be considered a reasonable cause for exceeding the benchmark. And just from personal experience, Michael, I would hope that as we develop the administrative guidances or the regulations for facilitating this process, as we set, the more that we can set some general guidance and parameters in writing, I think it will help facilitate the conversation down the road. I would just want to make sure that we add language to your point, and that is, here is some examples not intended to be all inclusive. And the only reason I say for some clarification in the guidance, Michael, whether it's administrative guidance or whether it's in regulation, is having dealt with the Division of Insurance, and I'm not saying this to be derogatory of the Division of Insurance, because this really came out of the AG's office as a guidance interpretation for the Division of Insurance. There have been times over history where initiatives have been attempted, believing that the law provided and allowed for it. And then you find out that somebody doesn't agree, and then they challenge, and you get a cease and desist order, and you go in and you say, well, the law says you can do you can do these types of pools or programs such as, and the interpretation of the AG is, unless it's said exactly there, then it's not considered. So in other words, such as, it is not opening it up for other factors to be considered. It's just saying these are the only factors that you can consider. So I hope that there will be language. There's so many variables that you gave examples and that Chris and others raised questions about, that I would hope that as we set the guidance on how we're going to facilitate this, because we're so new at this, there's so many unknowns that I would hate to see us get so narrowed in that we're not doing the quality work that could be done with the objectives here. One other general comment, Michael, is as you were talking about, we saw spend go down on the payer side, but then we saw spend go up on the consumer side. And so a question, this is kind of going back, but as I think about the contracting world out there between payers and providers, there's some providers who don't want to contract with anybody. There are some payers who don't want to contract with certain people. But what happens is networks get more narrow. The spend for the payers may go down, but the spend for the consumer goes up because they find themselves more often out of network now. And so their out of pocket's going to go up. So I hope that is something that we're going to look at as well. And the reason I bring that up, Michael, is because I served on the adequacy of network committee, advisory committee for the DOI for many years. And their focus was only on individual and small groups. And we never really looked at how some of these contracting behaviors, whether it's by the provider or the payer, is impacting spend on healthcare.
Okay.
And I know we have communities where there are payers who are not contracting for the only services that are available for a particular service. And so patients are either going out of network or they're having to leave the community.
Okay. Yeah.
So,
good points.
That's why I want to be careful on how we set the parameters and how we're going to look at this, that we're not excluding, we're doing it in a way that we're making sure that we're have the opportunity to look at any scenario that could be driving that factor.
Okay, thanks. Yeah, but also I'll restate there, except for transparency, there are no accountability consequences for health systems, health plans, medical groups, IPAs, for anyone for exceeding the benchmark at this point.
And Michael, I think you make a key point with your last statement at this point, because we are very new in the beginning of this process. And so I think it's imperative that being so new and understanding there's limited direction at this point in time, but we do know that we're all committed for a long-term solution. So this will evolve. So we got to make sure that we're starting it out in a way that's going to allow it to evolve, to take in all factors that should be being considered.
Okay, thanks. Maya, you had your hand up before. You want to say something?
No, that was an accident. Sorry about that.
Okay. All right. Anybody else have any comments that you want to add? Just shared a ton with you.
Oh, Michael, I did have one question. I did forget on, I mean, I'm very intrigued by the various analyses in the phase 1 and the phase 2. Would it be something where your folks could just send us links of some of the product that's been created in other states on those phase 1 and phase 2 reports?
Sure. Yep. Yeah, I'll work with Stacy. There are some other states that have posted content online that you could take a look at.
Okay, that'd be great. Thank you.
Yeah. All right, so we're almost ready to wrap up. So, so this is what's coming up in the next few months. In terms of cost growth benchmark measurement, no later than June 30th. The Department of Insurance is going to make a request for baseline data from insurers. and will distribute a implementation manual and wholesome trainings with payers. And approximately by the end of the summer, the payers will be asked to submit their aggregate baseline benchmark data to DHHS for analysis. In addition, hopefully, maybe by the summer, I'm handicapping maybe by fall, we'll have, by fall, we'll have some updated Medicaid and PEB phase 1 analyses that will have 2021 data included. And then next winter, we will share with you the PPC, and who knows, maybe even at a public hearing, the baseline benchmark findings. In terms of the phase 1 analyses we talked about, March 31st is our deadline for finishing those, and then beginning phase 2. And then we will review the phase 1 cost drivers with the PPC, and we will then review them with you, with them in April, with you in May. I talked earlier about this work on bills. The bills might target opportunities to slow cost growth, although the PPC's got broad discretion in terms of what they focus upon. They will vote over the summer on what their 3 bill drafts are going to be. Again, these are not necessarily linked to the cost growth benchmark, and they're going to discuss pre-filing requirements for them in the fall. Right, so several busy months ahead of us. The commission's meeting next week. We were to meet next on April 5th. As you saw earlier, we're recommending that we cancel this meeting and meet instead in May, specifically on May 3rd. I think I'm reading right, May 3rd. Chris?
Sorry, I just have a quick question. I was under the impression that we were trying to flip the content so that we saw stuff and could respond before the PPC saw it. Did I just imagine that, or did we subsequently decide we wanted it to be the opposite?
No, that is what we decided. I think just we had previously identified the timeline for doing the phase 1 driver analysis before we did the flip. I think that's the issue.
I just was looking at the stuff lined out and what you just shared, and it seemed like we're driving for this group to see everything after the PPC. So
yeah, no, thank you for that reminder. So that April 5th date, I'm just not confident that we're going to have the phase 1 analyses all polished and ready to present to you by then, because they're supposed to be finished by March 31st. And I've seen drafts of the ones that Kyra's staff are developing, and they're pretty far along, but the PEB ones I have not seen at all. And so if we don't get them until March 31st, I just can't imagine that they're going to come in pristine and be ready to share with you the next week. So that's the reason for this. But I appreciate you reminding us of our plan to have things go to you first, and then to the PPC. And as I say that, I'll also remind Stacy and Leslie that we make plans to be sure that we're doing that in the future.
Thanks. And I guess I just wonder, I mean, so maybe the March 5th date gets canceled, but maybe it gets shifted a couple weeks so that we can we do the flip for, we make the flip happen. I don't know.
Yeah.
Just a thought to consider.
Yeah, no, that's something that we can talk about. That's definitely an option. We've got an internal project management meeting on Friday, so we can talk about that then. Thank you.
Michael.
Be as honest. Yeah.
Michael, this is Bill. Along that line that Chris just raised, is it your understanding, or if there's somebody from the state could provide clarity, I would appreciate it. with regards to the identification of 3 pieces of legislation that the PPC has the authority to request, that was a very difficult and challenging process the last time for the PPC. Is it your understanding, or maybe Leslie or whoever at the state, is that something that the PPC is going to be able to say, I know we don't build consensus on any specific recommendations, Michael, but all of our input is presented to them, whether one of us or 20 of us agree with any specific statement. But will we get a chance to provide some suggested legislation that they consider that's in this realm of issues?
So this particular body was created to advise the PPC on the cost growth benchmark and not on the bills.
Okay.
I would say,
Okay.
Bill, if you want to do so, you're probably best to reach out to individual members of the PPC and convey to them your suggestions.
Okay, thank you. I just wanted for that clarification because there was a lot of confusion about that process going into the 21 legislative session.
Actually, Bill, you could probably, you can do a public comment or submit something for the record if you want, if you have suggestions that we can read into the record, and then they can opine about it.
Right.
Great.
Yeah.
Thank you.
Right. Okay. Anybody else have any closing thoughts before we wrap up? All right. Thank you all for your time and participation. You've given us a bunch of ideas to convey to the PPC and also for us to think about for our own work. So I appreciate that.
Thank you for the information.
Thank you, Michael. The next item on our agenda is.
Sorry. Oh. No, go ahead.
No, go ahead. No?
I was about to say farewell, but that would have been premature.
We do have a public comment agenda item. Does anybody, would anyone like to speak during public comment? If you're a caller, you can hit *9 and that would raise your hand. We have some attendees, but anybody can speak during public comment. Did anybody want to speak? I'm not seeing anybody. Okay, well, then I think that we can go ahead and adjourn. Thank you all.
Great.
Thank you, everybody. Have a great.
Bye,
Thank you,
everyone.
everybody. Have a great day.